one. So cool. All right, everyone, welcome once again. Tonight's is a little bit more of an exciting night instead of the boring old stuff we go through on Monday night, which is very important. I know I'm not underselling it, but it is somewhat boring. Tonight's is quite interesting. A little bit fearful for some of the level ones. I know this seems to be the one where they have a tendency sometimes to pack up bags and run home because they get a little bit scared or a little bit unsure of this. And to be honest, if you follow the protocols, I'll just get everyone to mute if you can, please, if you wouldn't mind muting for me. There's just some backgrounds on some of them. If you follow protocols, then you should be fine. You know, like we never really have too many instances with spinal where damage occurs because of what you've done. There are certainly instances with spinal that occurs from untrained people doing the incorrect thing, and it's very easy to do the incorrect thing. Something you've always got to remember is after any incident that occurs, like for example, a game of AFL, a game of league, a game of soccer, the players are pretty pent up. They're pretty well into the game. They're focused and they're there for a reason. They might be after a cup. They could be after, you know, a carton of grog after the game, or they could be after much bigger things. And when an incident happens, especially if they're hot and they've been working, there is generally a momentarily small piece of time where their adrenaline levels are so high that they will try and do some superhuman feats. You know, like I've seen a guy crash at 100 kilometers an hour, break both legs and try and stand up, you know, and when he couldn't stand up, he then army crawled across the racetrack to the other side, you know, which is stupid, I know. But at that particular point in his injury time, he felt he could do it because he was bulletproof at that stage. So that is very, very common. And this is where we see considerable damage can be done in the spinal area because what happens is people around them will help them up. And how do they help them up? They pull them up by arms and things like this. And of course, we've got some issues when that happens. So your biggest problem is not going to be you. It's going to be the other people around you or other players, especially because players don't want to stop the game if they're winning. Right? If you're on the winning team and you're in attack and the guy beside you gets knocked down and he appears hurt, you will straight away try and pull him up. Until you get to more professional levels, Laurie's not in here yet. He shouldn't be too far away. But more professional levels, that really doesn't happen. Laurie does a lot of tier one work in NRL, a lot of the big stuff for NRL, and those guys have a considerable more respect for each other than what the average player does. So it's something that you're going to have to contend with and try and manage at your level. And it's not easy, I can assure you. Spare with me 2 seconds. Right, where are we? Okay. All right, sorry about that. So I'll just share the slides with you so you can have a bit of a look-see at what we're doing. Sweet. Just got to pre-warn everyone. There are some slides in here which aren't pretty. There's a fatality slide in here. It's a fairly graphic close-up of a deceased female. And I just want to give everyone a heads up. If you don't like that, I'll give you a warning before that comes up so you can turn away. But it's fairly important within the whole event of things. Now, this course, PUAME 004A, is the national certification, provide emergency care for suspected spinal injury, okay? That is the unit. It's delivered. There's a stock standard period of delivery that it's got to be done in a certain way, and then we will fill it up with other stuff. So this is what the government requires, plus we've added a heap more to this over the years. We've done thousands of spinal injuries, absolutely thousands, suspected spinal injuries. I'm sorry, I'll be a bit more definitive on that. Do we get many real spinal injuries? Yeah, we do. Do we get many real spinal injuries in the ball sport area of our teams? No, we don't, but we certainly do in rugby league get a number of catastrophic spinal injuries, paralysis spinal injuries. So they aren't, we couldn't say that, that they're uncommon, because they do occur, and some of them are tragic, absolutely tragic. And they could have been prevented in a lot of cases. Now, in my area, where a lot of my stuff is high speed, we regularly get spinal injuries. Shakala was on a job with me the other day where we had one. She administered pain relieving medication to the patient to try and reduce the pain score he was in. And it's quite common. It's nothing for us to have a number in a weekend. Do we get many paraplegia or quadriplegics? No, we don't. It is quite rare where we get quads or paras. They're not common to us. Even though we do thousands of them, they're not that common. I've had a few in my career, but once again, it's not the norm. And really, you need to think of other things instead of thinking of whether they're going to be a quadriplegic or a paraplegic. We always take care, and we're always extremely cautious, and so that we're not being gung-ho. But a lot of instances now, in the past, level ones have never been taught spinal care at all, and in fact, most level ones, even these days, aren't taught spinal care. They're taught lock it down. Okay, so level one in many other courses will be taught hold the head and neck, do not move the patient, call an ambulance. Okay, ambulance comes roaring out the field, ambulance gets there, they go to the patient, how you going, buddy? Yep, okay, have a feel, and they find out it's his shoulder that is injured. Okay, so it wasn't his spine, it's his shoulder. So we've had a crew come out. How do I get that now? There we go. You've had a crew come all the way out, all the resources, and and QAS don't mind. Don't think that they do. They don't. Just that it's such a waste of a resource, when if the level one had been trained, they could have made that assessment. Now, some of you will be thinking, how can I assess that I don't need to call an ambulance? It's pretty simple in spinal related injuries, providing you follow the guidelines. Okay, if you have signs and symptoms, then of course call an ambulance. But if the signs and symptoms aren't connected with the spine and they're elsewhere, then you don't have a problem in that area. And this is something we'll discuss as we go. All right. The biggest thing for us and for you is mechanism of injury. That is absolutely vital. You need to make sure that you know the mechanism of injury of what's occurred. It is the single biggest thing that we look for, is the mechanism that caused this suspected injury. And some of you might not know what a mechanism of injury is. You may not understand what a mechanism of injury is. This is basically the meaning of it. It refers to the method by which damage, in your particular cases, we're talking about trauma, by the method by which trauma to the skin, muscles, organs, or bones occur. Okay. Healthcare providers use MIA to help determine how likely it is that a serious injury has occurred. Now, I'll show you now a mechanism of injury. Okay. This is one of the best videos for MOI that I've seen in many, many years. It's it's pretty incredible. Young Nathan, who is the writer here, gives us permission to use this video. We're very grateful for Nathan's generosity in this very embarrassing moment. Watch this.
Shit. Shit.
Mechanism of injury.
Yeah.
What was he doing? 60, 70 kilometers an hour, head on into a tree. Okay. So as you can see, that's mechanism of injury. So you've seen that. You've seen it's a bike rider. You can visualize how he's sitting. You can see he's hit the tree head on. What is your immediate suspect? What injuries do you think this rider could have? You can unmute, guys, and answer that. If you just want to have a bit of a swap around what you think it could be.
Oh, God.
I had to do the doctor's ABC, but I would always think first head and neck, because that's the one that you can't go back and say oops about.
Yep, head and neck. Jana, what else do you think could happen to this guy in here?
Internal limbs.
Yep, long bones, internal. So potentially with this guy, we could have, serious head injuries, spinal injuries, fractures, and of course, internal bleeding or internal ruptures. So he can certainly get it. So let's have a bit of a look how Nathan fared. Okay. So Nathan was pretty lucky. He finished up with a fairly severe concussion, and he finished up with a couple of fractures. So overall, pretty minor injuries for that amount of speed. And even if you take a look at the fracture, who wants to have a shot at what bone that is that's fractured there?
That's his femur, isn't it?
That's exactly right. Yep, that's what we call that's bordering on a NOF fracture, neck of femur fracture. It's right near the neck of femur fracture. So it could be classed as a proximal femur fracture or a NOF, a neck of femur fracture. So it's very, very close. So Nathan got out of that one pretty lightly.
Is that the knee on the left side there, Greg?
What do you?
Just in the joint of the leg? Is it
that's the knee. No, this is coming back up. You can see where the femur has come down. I mean distal. Distal femur fracture. Sorry, not proximal. What am I saying? You can see the radius and ulna, the tibia and fibula there. Sorry, you can see the large bone below the femur, the tibia, and you can see the fibula off to the side. And that's the knee joint. So he had no knee problems. He had no ligament or cartilage damage or meniscal damages or nothing at all. It was quite amazing, actually.
Amazing, right?
And he was pretty stunned when he actually witnessed that on the camera. So. Yeah. Like now, if you take a look at this, forget about all the hype that Red Bull have done with this. Forget about all the hype. I just want you to focus on the mechanism of injury. Okay, we do a lot of BMX bikes, competition, high-level competitions and stuff like that. Now, I just want you to focus here on the MOIs, the mechanism of injury, and also you get a quick glimpse of the MOI that creates this paralysis in this world-class rider. Okay. You get a very good look at the MOI, which is his crash.
Riders ready.
This guy's such a legend in the sport.
Look what they're doing. Watch it.
Making was
you can see enormous possibilities here. Of course, that's it.
So we just finished up with surgery. There is a chance that he's not going to walk again.
How many people have walked out of your hospital? He said, not many.
I was walking and a tree fell on me.
1 o'clock in the afternoon, bright sunny day, big intersection. I wasn't going very fast.
I dove off the back of the boat and hit the bottom of the river. The waves were 6 to 8 feet. The sun was out. I thought it was deeper than it was.
Dozed off behind the wheel, and that's when we launched off the overpass.
She put the wrong chemical in the epidural. It burned my spinal cord.
Just because I accept my situation doesn't mean this is it.
This isn't a broken bone where 12 weeks I can cut a cast off and start getting on with life.
We've all taken crashes, and what we do, we hit the ground and get back up.
Just want to walk, man.
You can't imagine the different world you live in, walking and not walking. I mean, it's possible that could be it for me.
If he sees that I'm happy, I'm hoping he will try to be happy.
Okay, we could watch that stuff, but we're mainly interested in what's happening at the time, not in the recovery later. So the big thing for you guys is you need to watch your game. You need to watch what you're doing. You need to watch very carefully what's happening, because the mechanism of injury is vital for you. I spoke to you on Monday night about mechanical and medical, okay? And this is another one of those right brain stuff that's out there in regards to what do I do? How can I tell something? And MOI, mechanism of injury, is so vital for you. Cleo, you would have been covering this second year. You would have been doing a fair bit of work on MOIs by now, or you should have been. And you know, like, it is so important. It's very challenging. Like, I take my hats off. As I said to you before, we've got a very, very, very close working relationship with Queensland Ambulance Service in Queensland, and I also have with CareFlight RFDS in the Northern Territory, and Ambulance New South Wales, and also Ambulance Victoria. Now, in most instances, in fact, you could say in more than 90% of instances, those on-road paramedics have no idea of the MOI. They arrive at a scene way after the incident has happened, and they become police investigators within themselves. They need to try and ferret out what information they can get to find out what was the mechanism of injury. Sure, they'll have what we class a windscreen view. So when they're driving to the incident and they're driving up to the incident, they're looking out of the windscreen or the side windows to see, what am I faced with? What is the level of damage that I can see? What's occurred? And they're thinking in their head, because in our advanced EMTs and our paramedics and nurses and all that we train, we talk about a thing called kinetic energy, kinesis. Okay, now, we don't teach that in the lower level in the sports trainer courses, because it really clouds your judgment. But kinetic energy is very, very important, and it is connected with mechanism of injury, because it gives us the amount of energy that was expended within that accident. Now, I'm going to show you an incident shortly where you think about the kinesis, the kinetic energy in this. 40-ton truck hitting an 1,800 kilo motor vehicle head on, truck doing 90 kilometers an hour, motor vehicle doing 100. Now, the kinetic energy is enormous. You know, is the little electric car going to come off in front, or is the double B semi-trailer going to come off in front? You know, we all know the answer to that, because we already understand kinetic energy in some way. The mechanism of injury of that accident is interesting, and you'll see some of the causation of that accident. But then you need to look at the patient and see, okay, what could be wrong with this patient? So, you know, it's interesting. Now, here's some really good kinetic energy hits for you, but the thing I want you to look at is the MOI. Some of these are a little bit difficult to see because they're older, but it's a good roundup of what some of you guys will face on a regular basis.
best team in the match. Locke's now done it, but the fact of the matter is they're still 8 behind. There's 6 remaining. Here is Clinton. Oh, he runs up! Oh, it's Mark Carroll up the chief. He ran at Rapani. There was no thought of arms in the tackle. Clinton ran into Rapani. It's the biggest collision of the night. Boy, oh boy. That's Tyson and Holyfield like. Clinton is sleeping.
It doesn't look good, eh? It's not good. Calling for assistance. Doctor is running out onto the field. Massive collision.
Now it's Dean Young. Will take a carry, and he splits them as well. Inglis comes up. Oh, and Inglis might have knocked him into tomorrow. Right there, Trent.
Watch the seizure, guys. Watch the seizure, and watch the fight over the top of the patient.
Because they come from everywhere. Trent Merritt.
Now the level 2 is trying to get into the patient here, but he can't.
There is obvious concern here for Dean Young, who was tackled from behind by Farrell as Inglis came up to him. He turned around.
There are signs that he's coming back. Here's O'Mealy.
So what we're not trying to get you to watch rugby league. All we're trying to do here is look at the mechanism of injuries of these. You know, like, and there's some big hits there. And of course, a couple of these people, a few of my people in here, and also young Cleo will understand. One of those players was in a decorticate position, which is not only a suspected spinal injury, he's also got a brain injury. So he did have a brain injury, he had a bleed on the brain, quite severe. So he, you know, like, it's just something that when you're watching the game, it's something you need to look out for. You should not be watching the game to keep score. You should be watching the game to keep an eye on your players. You should be watching the racing to keep an eye on the competitors. In fact, if you're a really good sports medic, you shouldn't even know the score, of the game unless you've heard it from one of the players. Because if you're keeping score, then you're watching the wrong part of the game. And I seriously question if you're more interested in the game than the welfare of your players, then honestly, should you really be doing that job? And it's just something that we see some sports trainers try and be a coach as well. Now, there's a very famous incident a couple of years ago over in Western Australia. It's a tragedy. Coronial inquiry occurred and NRL brought in sweeping regulations after this one. And what I'm talking about is at a particular rugby league game in the West, the president was the secretary, he was the treasurer, he was the coach, he was the ground controller, he was the sports medic, he was the level 1 and 2 sports trainer. He was man of all occasions, okay? And he was in charge of this game, and tragically this boy died. And he died at 7 o'clock at night from heat stroke. Heat stroke at 7 o'clock at night, okay? He was dragged off the field and propped up under a tree until he could get to see him later, because at that particular time he was coaching the boys who weren't winning. Some people at the fields went to the kid, called the 000, called 000 urgently. They said 000, and Johnny's, I think it was, or someone got there, and the guy was already deceased. They attempted resuscitation, but very, very challenging situation. So, need to be careful what you do. Laurie, would you concur with that about if you know the score and the ins and outs of the game, you're not doing your job as a sports trainer?
Yep, absolutely.
Like you do big NRL games, okay? You do real big NRL
absolutely.
games. And,
yep.
Do you really know what's intimately going on in the game itself, or are you tied up?
I'm glad you brought that up. I always say to sports trainers, if I'm running a course like you, if you know the score and who the best and fairest is, you're not doing your job. Our job as a sports trainer is to see what happens at the point of collision and the first thing that happens after a point of collision. We've got no time to worry about who's the best and fairest.
That's exactly right.
We've got an idea of the MOI. If we take our eyes off, we're gone.
We have a contract with a number of the major rodeo associations in the country, and also the camp draft people. And part of that contract says that whom we have on scene, the paramedics or AEMTs we have on scene, we have to be able to guarantee that they are watching every ride in that event. Yep. Okay, so now if something happens and they can't watch it because they're treating, the event has to stop. So it just gives you a bit of an idea how important that is. I'm just going to flick a slide up here, guys, in a sec. Now, this next slide is not a pretty slide after this one. Okay, so if you're a bit concerned about anything like this, then I'd suggest you look away until I tell you to come back. This is the incident. Now, if you've got kids around there, I'd suggest you clear them away. So this is the incident. Take a look at the size of the truck. Okay, it's 38.5 tonne. Take a look at the little electric vehicle, and you can see how that's going to come out of it. Now let's go and have a look at the female passenger who tragically is deceased, and have a look. Now you've seen the mechanism of injury. What injuries do you think this person has got apart from being deceased? Okay. Well, one of the first things a lot of people see straight up is the fact the cause of the accident, and was officially the cause of the accident, was she was on her mobile phone. Okay, so you can clearly see the mobile. You can clearly see the damage the mobile phone has done to her body. Also, it's been fairly aggressively embedded into her chest wall. Now, this is a pretty typical scene that when these things are involved. A lot of people say, well, how do they know she was using the mobile phone? Hello, you know, doesn't take much to see it. Now, the issue with this, a lot of people will think she's got massive spinal injuries. Well, in fact, her spinal column was intact. Her spinal column was intact, and there were no fractures in her spinal column, which is pretty amazing. The autopsy showed no fractures in that spinal column, no fractures in C-spine. Okay, she's got fairly, I wouldn't say massive, but I would say fairly extensive facial trauma. Okay, and obviously lower limb trauma is severe. What killed her? Okay, what killed her was the enormous trauma to the body and the aorta being ripped clean out. Okay, so, you know, not much recovery from that. I don't care how quick you are on scene, you're not going to help that one. She's a goner from when it hit. So mechanism of injury is vital for us, absolutely vital. Now, I'll share with you a critical incident scene of one of ours, and you'll see that on the left, you'll see we had like, I think it finished up with 12 or 13 QAS paramedics. We had 4 critical care paramedics, the chopper crew with another critical care, and of course an emergency physician off the chopper on scene, including all of our people. Now, you'll see what's his name's daughter, Laurie, Peter's daughter, laying down there on her tummy, and now this is something we did. This is a considerable period of time into the scene, into the incident. Okay, I was Haley and myself were first on scene, and we had a patient that was completely asphyxiated. Okay, his helmet he was profoundly unconscious. Okay, so he did not know he couldn't breathe because he was profoundly unconscious. His helmet was pulled up from the incident, split in half, pulled up, twisted, and got him here on the airway. And this part of his airway was completely white because of the fact that the helmet had asphyxiated him totally from the incident. We carry shears on our hip, and I managed to very quickly, with 2 of my shears, cut off the helmet to try and get an airway back for him. Now, then Haley went into what we call mills, and I'd like you to adopt that terminology, please. It's a terminology that you can use all the time. And, you know, mills stands for manual inline stabilization. Okay, now think about those words. It's manual, you're doing it. It's not a collar. Okay, inline means the spine is in line with the torso, and the spinal and the neck head is in line with the spinal column and the torso. Stabilization, you know, so you are stabilizing the head and neck in line with the spine and the torso. That's exactly what you're doing. Now, the problem with that, it immediately takes one of your resources away. So there was only 2 resources on scene, me and Harley. Okay. Now we knew. Now some people will say we don't need to do mills. Now that this is something I want to throw in there for you, because we've got some highly qualified people on this Zoom. Some people will say you don't need a collar when they're unconscious, okay, and you don't need mills when they're unconscious, all right, because they're not going to move, all right. So, and that's fair comment, all right. That is fair comment, but we had a situation, the way the patient was laying, take a look at the undulating track he's on. The racetrack where he crashed was quite undulating like this. And we were concerned that through our assessment of the patient, we were going to move the patient in a dangerous manner. And I wasn't happy to allow us to do that. So I requested Haley to do mills. All right. Now, this is a decision you may need to make on the day. Let's say we're at an AFL ground in Rocky, okay, perfectly flat, grassed, not an issue. Would I have done mills at that stage? Most likely not. Okay, I would have immediately attended to the patient until I could see level of consciousness increasing, and then I would have had someone immediately go to mills. So that's the reasoning for Mills. Now, the problem with that, as I've already said, is there was only 2 of us on scene. We were waiting for others to respond to the scene. The patient was critical. He couldn't breathe. He was unconscious. We didn't have a stable airway. We had a distension in the stomach, so he was bleeding internally. I quickly listened with my stethoscope. We had a hemothorax in the left-hand side, and we had an extensive pneumothorax in the right-hand side. So his chest wall was crushed. His right lung was gone, and his left lung was filling up with blood. So, and there was only one of us attending to that, which was me, until more arrived. So it was very, very, very challenging. Now, the issue with this guy was he woke up. So the Mills was needed. I needed help. So I called in one of the officials from the committee. This young lady laying on her tummy is one of those officials. She's actually the scorer for this event. She does most state events scoring. We taught her what to do very quickly. And the most comfortable way in a situation like this, because I knew this extrication would be a good hour plus. So she's going to need to be in a stable manner for at least an hour. So we had her lay on her tummy, and she was able to slide her hands in, hold head and neck stably so the patient couldn't move it. And she could chat to him if he woke up. Because remember, her face is here, his head is just there. So she could chat to him, reassuring him, everything's okay, ambulance is coming, rah, 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 okay? All the nice stuff to keep our patient calm. Because at that stage, Greg's not going to be too nice. I'm pretty busy, okay? So someone else patting him on the head is fantastic. Now, it just so happens this gentleman laying on the ground with his knees elevated is Australia's 2-times champion, world champion, and United States 2-times champion. He is Mr. Motocross. He's the most well-known motocross rider in the country, okay? And to see him in this situation was just terrible. And now, let's go back to what was wrong with him. When he woke up, he was fairly lucid. His GCS came back to, well, it was close to 15, actually. Sorry, level ones, we'll talk in your terminology, AVPU, which we'll discuss later on. He was basically alert, okay? So AVPU is a way a level 1, level 2 can ascertain how conscious is my patient. A stands for alert, V stands for verbal. They respond to verbal. U stands for unconscious. P stands for pain, and U stands for unconscious. So AVPU. So on your scale, this guy was alert. When we originally got to him, he was a U. He was unconscious, okay? So he didn't respond to talk, and he didn't respond to pain. So he was a U, unconscious. But now he's alert. For those that use GCS, he was 15. He was that close to 15, it wasn't funny. And he was extremely distressed about the pain in his spine. His spine pain was horrendous. He didn't know about all the other critical injuries he had. So I waited for more bodies to arrive on scene. When I got more of our people on scene, I wanted to effect a 3-on-3 spinal log roll. And now we'll show you a video later on how to do a 3-on-3. And I want you to remember that video, and you can show me and you can show Laurie when we do face-to-face. So when we got enough people, we rolled him, cut his clothing. We'd already cut his clothing off, his shirt, etc. We rolled him, and look, I started palpating, but we could clearly see the spinal fractures visually. I could see them. So I palpated. Now, the secret is, guys, you need to use 2 or 3 fingers, whatever you feel comfortable with. Okay, you've got your gloves on, 2 or 3 fingers. You start right up high, and you palpate carefully all the way down the spinal column. You're feeling it all the way down, and you need quiet around you, and you need response from the patient about what's happening, okay? If the patient's unconscious, don't even try this, okay? So you need response from the patient. and you're trying to find out where is their pain. You're trying to feel what we call step ups and step down. And Dean in this incident had 3 step ups and 2 step downs. He had 7 spinal fractures. Okay, now we could clearly feel this. So when you get to them, there's a little pen. You all know it. It's called a Sharpie. Okay, every one of our people has a Sharpie in their pocket. Some has one in their front pocket, their back pocket, and their side pocket, because we use Sharpies a lot. Okay, so you get your Sharpie, and where you felt that spine pain, where they're complaining of that spine pain, you pull out your Sharpie and you go either X or you circle it. Okay, not to the side of it, exactly where the pain is. When you palpate that pain and they tell you, you mark that pain. Okay, once you mark that pain, then you can tell QAS later on that this is where it was. Okay, so we finished the spinal assessment. We ascertained that he was in a critical situation. We lowered him back to the ground and continued on. QAS was en route. We knew they were en route. We requested code 1A responses. We requested multiple assistance, and we went through the procedure. Now we come to the stage of giving pain relief. Now, level 1s, the only pain relief that you can give is paracetamol, ice, and posture. Okay, so paracetamol, ice, and posture. Queensland Health allows you to give paracetamol, providing, now please listen to this, to conform to Queensland Health's guidelines, Queensland Health's requirements. We have a letter from Queensland Health, which we can copy your clubs if they wish to have a copy of that. The thing is that you cannot go into a pharmacy and buy a scheduled paracetamol, all right? You cannot walk into Chemist Warehouse, Blooms, whoever, and buy a 100-pack of Panamax, okay? That is a scheduled drug. It is illegal for you to have a scheduled drug, all right? So if you want to take paracetamol in your medical bag for your sports trainer job, you need to either buy it from Aldi's, Coles, Woolies, IGA, any of those places where you can buy a box of 20s, okay? They are non-scheduled and you're able to use them. Please never, ever, level 1s, pack Nurofen in your sports bag. Nurofen should only be dispensed by a physio or a doctor, okay? Do not dispense Nurofen. Nurofen will create bleeding. If it's a soft tissue injury and they want some pain relief and you give them Nurofen, you've just delayed the healing of their soft tissue by a week. Paracetamol, I'm happy with. Now, you can also carry, if you're doing kids teams, you can also buy in Woolies or Coles or any of them, baby paracetamol, baby Panadol, junior Panadol. You can carry them, okay, with you. Like I carry baby, junior, and normal paracetamol. And Queensland Health require you to administer that dose as per the instructions on the box or the label. So don't try and think you're funny because you can buy Panamax for 100 for $2 and you're going to take the strip of Panamax out of the box and you're going to put that in your bum bag and they'll never know. Of course they know. They're not idiots. Okay, so to abide by the rules, just go and buy the 50-cent packet or 80-cent packet or $1 packet from one of those shopping supermarkets and put that in your bag. And you can also buy the liquid forms there as well. So that is your pain relief. So you've got paracetamol, you've got posture. Okay, posture is moving them where it doesn't hurt, and ice for 10 minutes only, but we'll discuss that later. Now, in this instance, for the other ones in this course, we're doing pain relief, I think, tomorrow night or something. Some of you are able to carry, anesthetic. So please remember, is that before you administer that methoxyfluorine to a patient like this, you have to remember that a cough with young Dean here, if Dean coughed on me, we could have paralyzed him for life. Okay, so I actually had a consult with our anaesthetist on this. While I was at the scene, I called our anaesthetist to our medical director to discuss with him the danger of administering this drug to this person and making him cough, but he could hear the screams in the background. And he said to me, if you look at the pain he's in, if you don't do something, you're going to do more damage from that than anything. So we decided that we would try and restrict coughing by only letting him take small doses. And we didn't have a cough problem. We knocked out his pain, and then away we went from there. So, you know, this was a very, very tragic scene. And but it's one that's good for you guys to sort of see and have a look at. So let's have an introduction on a few things. Your spinal cord is this bundle of nerves similar to a fibre optic cable, okay? It's like an optic cable heading down your spinal column. It's about 43 centimetres long. It's 2 centimetres wide. And it's the link between your brain and everything else you do, okay? This is everything you do is controlled by this cable, all right? If you damage, sever, crimp, impress on it, or anything like that, you're going to see a problem. These figures are pretty well current and up to date. I rechecked them again last week. There's about 350 to 400 SCI. They call them SCI, spinal cord injuries, that are sustained every year in Australia. 54% of those are quads. Okay, 46% of them are paras. Accidents are the most common. They cause 4 out of 5 of those 400 spinal injuries a year. 4 out of 5. Okay, traffic accidents account for 2 out of 5. Roughly half of these people are in vehicles such as drivers and passengers of cars and trucks. The rest are mainly other road users, motorcyclists, push bike riders, and pedestrians. Typically, more males than females experience SCIs. 5 to 1, guys. Go to a spinal cord unit and have a look in a spinal cord unit. There's 5 to 1. Gives you a bit of an idea about the guys, how they like to jump off cliffs and show off to the girls and stuff like that. You know, and they wonder why they finish up paralysed. The most common injury level, now it's really good for you guys to know this, nearly 1 in 5 spinal cord injuries, the most common level is C4, cervical 4. Now you can all touch C4, go to the top of your spine, feel up into your skull, come down, and all of a sudden you'll feel your spinal column. Count down to C4, and that is the most common one. Now, some of you may feel, when you're feeling down there, some of you may even feel a bit of a bump there, okay, which is our living and how we go. The older you get, the more of a bump you'll find. That is the most common injury level to cause lots of troubles. It is then followed by its brothers, C5 and C3. So below it, one above it. And then we drop down to T4, thoracic. And then we drop down to lumbar, okay? So they're the most common injury points. Falls are the second most common cause, accounting for another 1 out of 5 accident-related injuries. 2/3 of these falls are from a metre, and the rest are from less than a metre, okay? Less than a metre. So the current statistics show a fall of greater than 600 mil. That's 2 school rulers, 600 mil. A fall greater than 600 mil should bring to your highlight query spinal. Okay, greater than 600 mil. So let's take this to everyday life. Let's take it to one of your AFL ruckmen, 6'3", 6'4", 6'6", and he falls from his own height. Someone crash tackles him and he's falling 6'6" to the ground. Okay, is there a suspect of spinal? You better believe it. And this is why you should never discount this unless you're clearly sure that you're okay. Water-related accidents, diving into shallow water, surfing, swimming accidents are another common cause, and they account for 10% of accident-related spinal cord injuries. If there's any surf lifesavers in this, you know exactly what I'm talking about. People running down the beach, big shallow dive into the water, hit their head on the bottom of the sand. Next minute, they can't walk, they feel funny, etc., etc. So spinal cord injuries can also occur due to medical reasons. You would have heard in that outtake before where that lady said she's paralysed because they injected an epidural and they injected the wrong drug into her spinal column. and it dissolved her cord and she's now paralyzed. Okay, and that does happen. It shouldn't happen, I know, but it does happen. Another is infections. Some people can get meningitis and things like this, which can also come from the brain and go down to the spine. Economic costs. What's it cost you and me as the taxpayer? You know, with greater than or less than 10,000 people in Australia have an SCI. Greater than, sorry. Lifetime cost per incident of paraplegia is $5 million apiece, each person for a para. Now, a quad is $9.5 million. $2 billion annually is currently being paid out. And according to some of the statistics I've seen since COVID, it's got a lot worse. So if we look at the level of injury, you can see there, you can see your cervical vertebrae, your thoracic vertebrae. So we talked about the C, the T, the L, and the S. Okay, so you've got cervical, thoracic, lumbar, and sacral. Okay, so they're the different areas of your spine. Now, this is not an anatomy course, and we're not going to spend too much time on anatomy in your training. You guys should do a bit of study yourself on anatomy so you know a bit about where things are. Like if you take a quick look at this, cervical injuries can result in quadriplegia. That's where you can become a quad, okay, is from cervical. So it's quite concerning. Now let's look at the actual column itself. I find it very interesting because you'll see that we have the anterior and the posterior. So the anterior of a body is the front and the posterior is the rear. So you can see this arrow pointing to the front and you can see what your column looks like. And when you look at the posterior side of it, you can see the spinous process. They're those little bumpy things you can feel when you rub your fingers up and down. And there's the transverse process there. And if you take a look, you'll see the cord coming up between these bony fragments, and it goes about 43 centimeters. That's all. It doesn't go all the way down your back. It only goes about 43, which, to put it in terminology, it's about L3, about lumbar 3. So if we go back a slide, so it finishes at about there, round about there, your cord will finish. There's no cord down here. Okay, so, excuse me. So if we look at this, look at the cord going through here. Now, coming off of this cord are all these nerve bundles, okay? And they're right down through the body. And it's amazing that they've got a little space. See that little space there between, you'll see the facet joint and that transverse process, spinous process, and this little nerve bundle shooting out of there, and that's heading off to your heart, or that's heading off to your lungs. That's heading off to, you know, to allow you to do a wee, or to allow you to breathe, anything like that. And that's where that nerve bundle's going. It's quite amazing. Now, you imagine that your football player's just been twisted on the ground. His spine's been twisted. His facet joint has been fractured and it's moved. And guess what it's done to that nerve bundle? It's crimped it. Okay? Just a touch. Just needs to be crimped a little bit. And your patient is immediately going to show you some interesting signs and symptoms, and we'll discuss them shortly. So that's all it takes. Now, that's not cord damage. That's nerve damage, okay? I had a patient, you see this transverse process there? I had a female patient who
Greg, we lost you there. We lost you there for a little bit.
Yeah, just for a little bit.
Sorry, we heard you talking about.
Yeah, you're back now.
The AFL player, and his nerve bundle gets crimped. That's the last thing we heard.
If his nerve bundle gets crimped, you're going to be presented with signs and symptoms of that player. In a lot of cases, it'll be paresthesia. Now, we'll come back to that paresthesia a little bit later, and you can take some photos of what the signs and symptoms are. But you imagine that's a nerve bundle issue. That's a nerve bundle compression. You imagine now if that bone was broken and it penetrated the spinal cord, okay? I had a female patient in soccer. She was about 30 years of age. She got tackled quite badly. Feet were taken out from underneath, illegal tackle. Feet were taken out from underneath her. And the transverse process was fractured. It turned around and penetrated her cord and went straight into her cord. And she was immediately paralyzed from just below her rib cage right the way to her feet. She dropped to the ground. She could not feel nothing. She could not feel her feet or anything at all. And we were very, very concerned. A helicopter was flown in. Helicopter landed on the field. She was extricated. She was flown to the hospital. They flew her to the spinal unit in Brisbane. And then they took scans and MRIs and everything else. And the surgeon then made the decision that he believed he could operate on this, because to him, he could remove the transverse process and it should be okay. So they turned her upside down and operated on her and removed the transverse process, and she's had a full recovery. Often see her in the shopping centre if I go shopping these days. It's quite amazing, you know, how it can happen. But then, of course, you get the other situation where the cord's been severed, and just a tragic situation. And there's nothing they can do about that at this stage. All right. Now, what we were talking about was all of these nerve bundles. There's 31 pair of them, guys. 31 pair. They control everything. And let's have a look at what they control. And there it is. So they control your eyes, tear glands, nose, your palate, submaxillary and sublingual glands, the salivary glands in your mouth, heart, lungs, stomach, blood vessels, liver, pancreas. Everything is controlled by this. That's why in some serious spinal injuries, you may see a male patient with an erection. Okay, those of you that watched that NRL game of tragedy when he was paralysed, he had quite a large erection that could be clearly seen. Now, the reason for that, of course, is the nerve bundles have been affected, and this is what's gone on. So take a look at the little wording on the right-hand side of that picture there, paresthesia. Now, these are signs and symptoms of spinal injury. These are issues in regards to spinal injury that aren't commonly talked about, okay? You can take a picture of it if you want to, but let's take a look at it. Paresthesia, we'll cover again shortly. Salivary gland issues. It is a sign and a symptom sometimes of spinal injury that the player has extremely dry mouth. Okay, now if you're working in the ball sports and you've got yourself water runners, and that water runner's beat you to this injured player, okay, he's beat you there, and they've filled this guy's mouth full of water, you've just lost your ability to be able to help with the diagnosis of what's going on. So we like to keep them away. Slow or irregular breathing, we call it bradycardia. Their breathing can slow all the way down. Incontinency, they can wet or defecate, okay? Priapism is an erection in a male. Pain, tenderness, step-ups, that's where the bones are stepping out, or step-downs, where there's a hole down through the spinal column where the bone's gone inside. And vision, they may have vision impairment, okay, which once again can be related to a spinal injury. All right, basically the one on the left's para, the one on the right's a quad. So the last thing any of us want to become is a quad. Just show you a quick critical spinal injury we had about 4 years ago now. Very, very dangerous jump, highest jump in Australia in motocross. It's an illegal jump and it was banned after this accident. What you may not know, there's two bikes there, okay? They're at speed, big jump, two bikes, got tangled with each other. Now you can start to see the second bike separate out. The bike at the rear's got hold of the front bike. You'll notice he's tipping him at a normal angle. So the front bike's wheel is not coming down how it should. Bites the ground, of course, hits the ground very hard. The top bike is now on top of the rider. and that top bike throttle is stuck on. So he just proceeds to whirl around and around and around and around. He's burying the other rider underneath him, still burying the other rider underneath him, and he's still burying the other rider underneath him. So the photographer got a really good run of these pictures. So when we got to the patient was absolutely screaming, and he was complaining of severe pain in his hip. Okay, we cut some clothing off, and unbelievable. There was a 30-centimeter laceration down this guy's side of his body, across his hip and onto his back. 30 centimeters of about better, nearly down to second knuckle depth. It was quite traumatic injury. Now, we did, whilst on field, we did a complete spinal check 3 times. Okay, we rolled him. We did a full assessment of his spine. He had no paresthesia, so he had no pins and needles. He had no burning spots, no cold spots. He could move all limbs. He could flex his feet. He could squeeze my fingers. Neurologically, he appeared intact, and there didn't seem to be any issues with this at all. What he was complaining about was the enormous wound on his body, and we needed to give drugs for that, which we did. We took basic spinal protection with this patient. We didn't take advanced spinal protection. We took basic spinal protection. And we loaded him up, put him on the back of one of our vehicles, and transported him back to the medical centre, where New South Wales ambulance arrived on scene, and then got him up off of our bed and walked him to the ambulance, and walked him up inside the ambulance and laid him on the bed and transported him to the hospital. About 2 hours later, the ambulance New South Wales paramedic came back, and he was as white as the white shirt he had on, expressing his sorrow that he made a mistake. And I said, "Oh, I don't think you did, mate." I said, "It tricked us too." It turned out this young man had 11 spinal fractures, critical spinal fractures. He required 9 hours of invasive spinal surgery. He was helicoptered out to the John Hunter neurological unit, and the surgeon from there rang us and needed copies of the photos so he wanted to know the MOI. This patient had no signs and symptoms of a spinal injury. The surgeon discussed this with us, and as he said, there's a thing called masking pain. We're all taught masking pain. Every paramedic is taught masking pain. And masking pain is the biggest lesson you can learn in treating spinal injuries. If a patient has an overruling pain that is very, very painful, like a 30-centimeter, very, very deep laceration on their body, it can mask or hide a critical spinal injury. Okay? So you need to be very, very careful with this. If you've got a secondary issue, which at that stage you would think is your primary, and that is some other form of serious injury, is that masking your spinal injury? Are you better off then, if the mechanism of injury isn't good? Hey, and you all saw the mechanism of injury. Was it a good mechanism of injury? Of course it wasn't. It was terrible. Like it smacked and smelt to me of spinal. Karen was on duty with me as well on this, and I kept saying to her, this is spinal. All the way, this is spinal because of the MOI, just the MOI. And we took basic spinal precautions because of the MOI. They didn't. And, and this is what can happen. So it's just a lesson to be learnt, guys, something that I strongly suggest to you. High cervical nerves, it's the most severe form of spinal cord injury. Okay, high cervical is the worst. They can suffer paralysis in all these areas. So it's not the best place to have an injury. L1 to L5, lumbar 1 to L5, to lumbar 5. Injuries generally result in some loss of function in the hips and legs. Little or no voluntary control of bowel or bladder, but can manage on their own with special equipment. Sacral nerves right down below, down in the sacrum. Injuries generally result in some loss of function in hips and legs, little or no voluntary control, or once again, a bowel or bladder. Now, moving from your primary survey, your DRS ABCD, into your secondary survey, you're only to commence the secondary survey once you've done your DRS ABCD, okay? Then you can take on your secondary survey, especially in regards to spinal trauma. Take an adequate history from the patient and the bystanders. So see what we're trying to do, mechanism of injury. If you didn't see it, find out what happened, okay? Just don't go assuming it. Use the AMPLE acronym we spoke about the other night, AMPLE, allergies, medications, past medical history. Hang on a tick, sorry. So allergies, medications, past medical history, last meal eaten, events leading to the injury. Do a head-to-toe examination. A thorough examination of motor, sensory, and reflex capacity is crucial. So go to their feet, get them to push against your hands. Lay your hands up on the top of their boots. Push against them a little bit. Get them to push against you. Is the push against you equal on both sides? Or do you find one side is weaker than the other? Drop your fingers over the boot. Get them to pull their toes back on you, okay? So hands on the boot or the feet, the gloves. Drop your toe, drop your hands over. Are you happy that they're equal? Okay, yep, they're equal. Get the hands, go up to the hands. Now, long life lesson, do not give big footballers your hand to squeeze, okay? They'll break it, okay? Little tip. I give them my fingers, okay? Give them my fingers, squeeze these fingers, please. So they've both got to be done together. So you put fingers down, squeeze these, John, squeeze, 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 squeeze. Shikali, remember the patient the other day? He had deficit, remember? Left side deficit, I think it was, in both his feet and his hands, didn't he? So he had full left side deficit. So what we mean by that is...
It was right.
Yep. What we mean by it is his right side, when he squeezed my fingers, I could immediately feel his left side was quite weak. When I did his feet, his left side was quite weak. So we don't do it 20 times. We do it once. I made a mental note of it. I shared it with the team that were with me, left side deficit. When he was taken back, because we have a protocol, the emergency crew on scene transports back to the centre. One or two of the people from that emergency crew stay with the patient. In this instance, Shikala and someone else stayed with the patient, and another crew come with me. And then when they take them in, they hand over to the supervisor back at the medical centre, and they can say to that supervisor, we have left side deficit, we've got this, 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 and this. QAS crew arrive on scene. Straight away, we've got a summary of problems that we've got, and we can say to QAS, this is what we've got. Bang, 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 bang. We have a procedure we give to them in a certain running order, so that everyone knows exactly what's going on. You need to do that, okay? You need to know what's going on here, so you know what the problem you've got. Okay, head and face, okay. Examination should be conducted with the patient remaining supine on their back. Inspect the face and the scalp. Look for any lacerations, bruising, around the eyes, the mastoids, which what we're looking for is a baseless skull fracture, and that can be spinal as well. Palpate for any depressions or irregularities in the skull. All this kind of stuff is in your secondary examination. Neck, no midline cervical spine tenderness. So you're checking in the neck, no midline. Now you notice that word midline. Very important, level ones. Remember the word midline, because you will often get players, and I'm telling you now, this is going to be, it could happen in your first week on the job. You'll get a player complaining of back pain, and you'll go, oh, Jesus, spinal. And they're saying back pain, but it really isn't spinal. You start to do an assessment and you find out, you check the middle of the spine and you find out it's 10 centimeters away from the middle of the spine, up in the shoulder somewhere, okay? And this is where things get confused. So we will be having you do this check. So check midline cervical tenderness. Any neurological deficits? Have they got either of those deficits we just discussed? Are they drunk? Any evidence of intoxication? And don't tell me they don't drink and play, please. They do. Any painful, distracting injury? Okay, any painful, distracting injury. You know, if his leg's there and his foot's facing that way, and it's definitely broken, that's a distracting injury, okay? So you could have a spinal too, be careful. No altered mental status. So focal neurological deficit. Motor or sensory examination indicates the presence of a focal neurological deficit. That's a big fancy word to what I said before. He's got a deficit on the left or the right side. Painful distracting injury. Now this is a bit of a list of some painful distracting injuries. Long bone fractures, visceral injury requiring surgical consultation, extensive laceration, crush or degloving injury, okay? Considerable burns, any other injury producing functional impairment, any other injury thought to impair the patient's ability to appreciate cervical spine pain. So it's just a good idea for you to look at those. Altered mental status. We'll talk about that later on for level ones. Neck exam. To ensure adequate access, have another colleague maintain mills while the collar is removed for palpation and throughout the examination. Gently palpate the cervical vertebrae. Note any cervical spine pain, tenderness or deformity. The point of maximum tenderness should be noted, marked with your Sharpie. Deformity may be felt in significant vertebral disruption or dislocation. Check the soft tissue for bruising, pain, and tenderness. Complete the neck exam by observing the neck veins for distension and palpating the trachea and the carotid pulse. Note any tracheal deviation or crepitus. So if you see the veins are quite strained out, this could also be part of a spinal injury. Not worried about that one. Log roll the patient. Maintain inline stabilisation throughout. Inspect the entire length of the back and the buttocks, noting any bruising and lacerations. Palpate the spine for any tenderness or steps between the vertebrae, including a cervical examination. Many patients with a spinal cord injury have vertebral injury at more than one level. Do not sit the patient up. Digital examination should be, you just aren't doing a digital examination, okay? No fingers in the glove going anywhere they shouldn't go, please. If you don't know what a digital examination is. The big thing for us is movement, okay? Waigoi here, we don't like the Waigoi movement because flexion and extension can cause, change the diameter of the vertebral canal and the cord itself. So this kind of stuff is not good with a spinal cord injury. Mechanism of injury is basically what I'm saying. You might want to take a photo of this. Here's some real good signs and symptoms for you. And head or neck pain, neurological deficits, tenderness in spinal area, deformity of spine and palpation, altered level of consciousness, incontinence, bradycardia, that's, low pulse, hypotension, low BP, hyperthermia and hypothermia. So all of a sudden they might be boiling hot, next minute they're freezing cold. Signs of shock in trauma patient who has no outward sign of bleeding. So all of those things are suspicion. Now, if they've got any of these things, treat it as suspicious spinal, get an ambulance. So the basics for you guys on the field, on the racetrack, wherever you may be, stage one, recognize the possible spinal injury. Biggest thing, recognize it. 2, mills. 1 and 2 are important. 3 is all the toys. We call them toys. They'll come later. Toys are collars, boards, all this type of stuff. They'll come later on. Pardon me. But neutral position of the head and neck and the spine allows space for the cord, the maximum space for the cord, and is normally the most stable for the spine, okay? Babies are a bit tricky, okay? Take a look at them. They are normally in neutral position, so please try and remember that one. See that lady on the right? You can see how she's flexed and extended, but the one in the middle is perfect, okay? That's how we need her to put a collar on. Contraindications to a neutral position. When you can't have a person in a neutral position, do not return the patient to a neutral position if the movement causes pain. So let's say they're bent like this, and you go to try and straighten their head, and they're going, ah! Don't straighten their head, okay? Leave it where it is. Put a collar on in that position. You'll all be taught collars. A lot of the people on this know how to do collars. We teach both lots of collars, okay? I'm sorry, but we have to by law, because if you cross the border down south, you will be required to use a hard collar, stiff neck collar. In Queensland, we only use soft collars, all right? Soft collars and hard collars require you maintain mills at all times. You cannot put a collar on a patient and let their head go. You have to maintain mills all the time.
Northern Territory, Greg.
You're talking about my favourite place to work. What about it, Shane?
They're hard collars too.
Yeah, they are. Territory's interesting, mate, due to the fact really the only place you're going to get an ambulance that'll arrive on scene is Darwin. All right, you might get, for example, give you a classic example. We're in Alice, and we're on duty there. The boss for St John's. St John's is the government ambulance service up there. Okay, so we're in there, and the boss for St John's come and knocked on the caravan and gave me a hug. Never met the guy in my life before. Lovely guy. And next minute I know he's on the step of the caravan giving me a hug, thanking us for being there, to taking over the job that he didn't have to do it. And he said to me, he said, if you need a hand, Greg, give me a yell. There's only one problem. I said, what's that, Dave? He said, we've only got one vehicle on. He said, and I got 2 staff, and they've just arrived from England, so they're still settling in. So yeah, not a lot going on up there. Shane, if you have an accident on the highway, like we had a job at Daly Waters, critical job, had to get the jet in from Darwin, critical job. And they sent the Aboriginal ambulance from Mataranka. Now, Mataranka to Daly Waters is, hour and a half's drive with lights and sirens on. Like it was the actual aircraft from Darwin was 7 minutes behind the ambulance arriving. It was just crazy situation. Yeah, the St Johnny's are rigid collars. That's true. So it's, look, we carry both. Loza carries both. It's just the thing we do. What's the difference between them? Rigid collars should never be used. They're useless. They're painful. They cause all kinds of restrictions. And soft collars are useless. They do nothing. In fact, the recommendation is if you don't have a soft collar, just get someone's t-shirt, preferably a bright color, and wrap it around the patient's neck and do mills. Okay, so do mills, wrap it around the patient's neck. Because a soft collar does nothing at all. It is only a warning. And in fact, if you look at the QAS collars on the front of them, they've just got it's a little warning to say that it's suspected spinal injury. So it's challenging. Stiff collar versus soft. Yep, okay. This is the problems with hard cervical collars. They've been shown to be associated with potential harm. They're very painful, very, very uncomfortable. Restrict mouth opening, difficulty swallowing, airways compromised should the victim vomit. Pressure on the neck veins, they actually cause ICP, intracranial pressure, and they can hide life-threatening conditions like tracheal deviation. They can actually hide tracheal deviation. We can't even see. So if the patient's got a pneumothorax, their lungs collapse, and we've got a lot of pressure going up against here, and the trachea is deviating, we can't see it with a stiff neck collar on. So it's challenging. we'll come to collars in a minute. We don't use spinal boards anymore, okay? Just in case your club's going to go race out and buy a spine board for you, or they've got a spine board. If they've got a spine board, I'd suggest give it to some guy that likes surfing, and maybe he can put a fin on it and make it into a surfboard one day. Throw it out, get rid of it. They're too dangerous. Do not use spine boards anymore. We don't teach with them anymore, and we certainly don't use them in our practice. Our clinical practice guidelines outlawed them a long time ago. There's a couple of small studies. They are only small studies, but they were very definitive, and they only ever remained small because they were so impactful they weren't game to do anymore. Basically, if you put a patient on a spine board with no spinal problems, if they're on the spine board for any more than half an hour, when they come off of it, they will have a problem. Okay, so they are known to do damage to the back, and they hurt, so we don't use them. The gold standard, which none of you will use, we have them. They're hellishingly expensive. You aren't going to get any, so don't worry about it. But we carry spinal mattresses, which are hellishingly expensive. They're about $1,200 a pop. And but we use scoop stretchers, and scoop stretchers are what happens this day and age. QAS doesn't even have any spine boards anymore. They ousted them all. They just have their green jolly little giants, and that's all they use. So no spine boards. Now I'm going to show you a standing spinal takedown. We had to do one of these recently on a real patient. Now these are common in football. Laurie's done one recently also. I think you said, Loza, didn't you? Yeah. These are common in football. So AFL people, look out, okay? Because this can occur. Certainly common on the beach where this can occur. Look, this is a really good demo by the Lifesavers, and I thank the surf lifesaving community for doing this video. It really is a good demo. Look, it's a little bit, play acting. Please look through that and look at what's doing. You'll do this in your training. It's a bit frightening for the patient, but it does work. But it's a very, very good skill set to know.
A member of the public has fallen over and realised they've hurt their neck in the process. They've approached the Lifesaver complaining of neck pain.
I've fallen over in the sand and I've really hurt my neck.
Hi, my name's Rob. I'm a Lifesaver. What's your name?
Michaela.
Okay, I just need to take control of your head. Is that okay?
Where an appropriately qualified...
Now, what Rob did then was he introduced himself, he got a name, and guess what else he got? He got consent. Dead right. Straight up, he got consent. So he did all three in one little sentence. Well done.
Lifesaver is available, they would apply a correctly sized spinal collar.
Stay as still as possible. Amy coming in, she's going to step in behind you and take control of your head. She's going to slide her fingers in between mine. Okay. I need you to stay as still as possible. Okay. Have you got control of the head, Amy?
Yeah, I have control of the head.
Okay, I'm just
good communication.
I need you to stay focused on me. I've now got spinal board coming in. Board coming in behind you.
Once the Lifesavers have positioned the spinal board behind the patient, they will seek assistance from 3 more of their colleagues to manage the patient down to the ground.
So can you support the patient, please?
The 2 Lifesavers now move into position either side of the patient. One hand goes under the armpit of the patient, the other securing the next lower handle point on the board.
2 at the back.
See that, guys, how that went? I'll just take it back here. Look, be a little bit, kinder to your patient too. It's a suspected spinal injury. They're a little bit rough, but whoops, sorry, I'll just take it back up.
Have positioned the spinal board behind the patient. They will seek assistance from 3 more of their colleagues to manage the patient down to the ground.
So can you support the patient, please?
The 2 Lifesavers now move into position either side of the patient. One hand goes under the armpit of the patient, the other securing the next lower handle point on the board.
2 at the back, can you control the board? Everyone in position to lower? Yes.
The Lifesavers will now lower the board to the ground, taking command from the Lifesaver controlling the patient's head.
Amy, have you got control of the head?
I have control of the head.
Great.
Okay, we will start to lower on a count of 3 to halfway down. 1, 2, 3.
As the board is lowered, the Lifesaver in charge will ask the lift to be stopped to enable each Lifesaver to adjust their grip prior to continuing down to the ground.
And rest there. Just move my hands. Okay, lowering again.
Now, this is where you can have a problem. And I'm not being sexist. That's anyone that knows me knows I'm not like that. Females with larger breasts are now going to have a problem. Okay. And this is something that happens to us all the time. They need to be aware of this because this board is now going to get hooked up in their boobs and they're going to be in trouble. Because they can't relatively move because they're doing mills on the head. Okay, so sometimes it may be better to have a guy at the back, or it may be, as long as she is aware that she needs to keep her breast out of the board's way.
All the way to the ground. Down.
Once the patient is down on the ground, the first lifesaver will continue talking with the patient to access further information on their condition and circumstances, while other lifesavers monitor the patient, keeping them warm with a towel or blanket and treating for the initial symptoms of shock.
Great job. Okay, very good job, I thought. So we'll do. Yes, Loz.
Yeah, can I just come in there, please, and just stress to the team here tonight, one of the good things the guy did from go to woe is he told his patient exactly what was going to happen. This is important in spinal. They're very scared.
I've
had NRL guys really scared.
Yep.
So yeah, you've got to tell them. He was a very good leader, actually, communicating with his team and the patient. Always tell them what's going to happen, guys. Thank you.
Like
Thank you.
Dean Ferris, that incident before, like Dean's a good mate of ours now, and that job that in fact, I don't think I've ever seen a patient, an adult male patient, as scared as what he was. He was absolutely in fear of becoming paralysed, and he was begging.
Absolutely.
He was begging us, literally begging us, not to hurt him. So you need to talk with your patient. You need to keep them updated, keep them informed, and reassure them. That's why we say reassurance.
Greg,
all right,
I've lost your camera there, but I can still see everything, and I'm watching. So
okay,
I've just
mate.
lost the picture, so it's
no
fine.
worries at all. Okay,
Thanks,
thank you.
Guys.
Was that you, Barry? Sorry. Yep. Okay.
Yeah,
all
it
right.
is. Yeah, I've just lost picture, but I can still see. It's fine, guys.
If we take a look at this situation here now, this is a 3 over 3 under log roll. Okay, so this 3 over 3 under log roll is only used if you think you have a spinal situation. Okay, so you don't use this for a normal log roll. Okay, so we'll go through and have a look at it. This is in a hospital environment. This is a little bit tricky, and Laurie and I will have you do this in your courses, but it's a little bit tricky because this guy here, the head person, is actually, this patient's on a gurney, so it's much easier for him. Most of the time this is done, it's on a bed. So let's have a look at what happens.
This is a demonstration of a spinal 3 under and 3 over log roll. You can see here the tallest person is having his hands placed over the shoulder and the hip. The next person with a hand on the hip, on the bony pelvis, and the other hand underneath the thigh, and the last person with both hands underneath the calf. The point of this is a demonstration of a spinal 3 under and 3 over log roll. You can see here the tallest person is having his hands placed over the shoulder and the hip. The next person with a hand on the hip, on the bony pelvis, and the other hand underneath the thigh, and the last person with both hands underneath the calf. The point of this is to have 3 hands under and 3 hands over, supporting the upper leg when rolled towards the team. This means that the weight of the upper leg doesn't tilt the pelvis and then flex the spine. You can see the person in control.
You notice what the doctor's doing now?
Down, grasping the trapezius.
Notice the doctor's got his, that's right, he's got his arms around the head.
It's essential to plan these.
Look at the roll, beautiful roll.
Well, the team needs to know exactly what they're doing, which means you have to be very clear, ensure they're ready, and then give instructions such as turn right 90 degrees on 3, 1, 2, 3, rather than being unclear about when to roll.
Perfect.
The same thing occurs when rolling back onto the bed.
So as you can see, it's 4 people to do that role, and it will take 4 people to do that role properly. So you can get anyone to do it. You've just got to instruct them how to set that up. All right, just a quick video on. We're going to show this, Loza, or not? I don't think we need to show this, do we? Can't we do this on the dial?
We can demonstrate that. It's just as quick to demo.
Because it's just, we don't even use them anymore. Like, you know, it's waste the time. But okay. All right. So the big thing for us, removing a player from a sporting field. Okay. I spoke about the fact that in my job and Laurie's job and Shakayla's, and that is, we have to remove them. We're it. We're the ones that are there, and they're relying on us to get them off. Okay. So now Paul, who's on here, Paul works in an environment where some of the jobs he does at some of the particular areas, they're not happy to leave people laying on the field. They want them removed. They want the game to keep going. And, you know, I know this is wrong, but, you know, the directors or the people that are on these committees are orthopedic surgeons, spinal surgeons, and pretty well-heeled people at some of these places where Paul does jobs, and they want them off, get them off the field. So they're not happy to wait for an ambulance to come, whereas most of you others don't fit into that picture. Okay, so we have to remove them. We don't have any choice. So I just asked the question: if you've done everything we've spoken about and what we'll teach you in your practical, and you're still, your gut's saying to you there's a problem, I don't want to move them, then don't. Okay, it's as easy as that. I will quite often say in a major event, thousands of people involved, you know, time's on the clock, big money, and I will say to the boss of the event who's over my shoulder, not happy to remove the client. Laurie's been on numerous jobs with me where we've made that decision. You know, and the patient is critical. It's a life and death situation. We are not happy to move the patient. If we move the patient, it's highly likely they're going to bleed out on us. Okay, we will leave them where they are, where we believe we can keep them stable until a helicopter can extricate them from the scene. And sorry, guys, that's the breaks. We don't do that a lot, but, you know, it's there that we do it. And it's the same with you guys on a sporting field. But do what you're taught, follow what we've been saying, and go through your steps, look at your signs and symptoms, look at your palpation, look at all of this stuff and see how the patient is, and then make your decision. So some things are urgently need to get them off the field, storm, fire approaching, wild animals. Don't laugh, that happens sometimes. Sport dependent, collars. Why? Yes, you should be using collars. Okay, you should definitely be using collars. In fact, if you're trained in this and you don't use it, pardon the expression, you'll get your ass kicked by QAS. If you've made a definitive call, you've got a definitive suspected spinal here, and you're calling the ambulance, you make damn sure you get a collar on before the ambulance comes. Okay, get your club to buy some, or we can talk about what your clubs should have when I'm up there. All these other people have already got them. You know, I forget what we sell them for. If you don't want to get them from us, get them from Chemist Warehouse, $18 or something, depending where you go. Each you'll need a size of extra small, small, medium, large, and extra large. You need the 5 sizes of collars: extra small, small, medium, large, extra large, and have those in your case. If you're just working junior games, okay, then double up on extra small and small. And just keep them. Leave them in the plastic bag. You don't need to take them out of the bag. Scene management. Please manage the scene. We actually have, at a lot of our scenes, we have a scene supervisor. Okay, a scene supervisor. And that supervisor supervises the scene. Funny that, isn't it? So the DRS ABCD used to triage the patient. Never yell, please. We don't like yelling, thanks. Think before doing or saying. breathe, and overall communicate.
Greg, can I just come in there with the previous slide, if I may, please? When we're taking them away, some of the considerations that we take on board, and remember, I'm talking here as an EMT now, so some of you guys won't have that. We won't move them. They've got serious fractures and we don't have proper pain relief, especially with pediatrics. The other thing to consider there as well is that every patient you get is going to have different tolerances to pain. So if they can't tolerate pain, and we really don't know if they're putting it on or not sometimes, but if they can't tolerate pain, well, you may not have any choice and you can't move them, okay? And sometimes the environment that you're in may not allow you to shift them as well. So they're just some of the considerations we might just take on board. Thanks, Greg.
Look, like for example, to give you a factual thing on that, Laurie and I are on a job together, and we had an accident. We didn't have an accident, but this little boy had an accident. He was 12 years of age. He tragically, the track had dried out, and there was big ruts, and they were very, very hard. And he crashed, and he did the worst femur fracture you've ever seen. It was a terrible, terrible fracture, and he was hemorrhaging internally. He urgently needed blood. Needed blood, whole blood. Yes, that's right. And we don't carry whole blood with us, so it was a critical situation. And I made the call. I was not happy to move this patient. We were struggling a little bit with pain relief. We were getting on board what we could, but this kid he's 12. Kid kept asking for heroin. His father was there, and I took a look at his father. I thought, okay. And it was quite strange, actually. 12-year-old boy asking for heroin. And when QAS arrived on scene, it was a code 1 response for them. We were in a very regional community, and the QAS crew were taxed to the limit. So between us, we all worked together. Karen and Candida had to drive the ambulance, and it was a real team effort. We got the chopper straight in, and that it actually shut the event down. Queensland titles, they lost half a day because of us. There was nothing we could do. Patient would have died. I was quite confident that if Laurie and I would have moved him, we would have lost that patient. Yeah. And we made that call. I think everyone was happy with the call in the end. QAS was certainly happy with the call. And then the chopper took extensive time. The emergency physician on the ground took extensive time trying to stabilize this young little boy and try and get some whole blood on board. So did he have spinal injuries? Yes, he did. But, and it was a difficult situation. So sometimes you got to make that call, guys. So, and as I was saying, many's the same. Now, you guys in AFL, you're going to have a problem managing your scene. Okay, I'm telling you now. You're going to have people come from the woodwork that are going to be better than you. And they'll say they're better than you. And this is your single biggest problem. And then your area of concern then is your lack of confidence at this stage in your career with this. Okay, so, and I can understand that. Look, if you're an old hard-bitten RN out there and you've done some time in A&E or ICU and you've just done your level 1, you know what to say to these people. Whereas a lot of these others won't know what to say, and they can be shrinking violets with it. And that's a shame. You stick to your training, okay? Do not move from your training. Stick to your training. So you stick to it, you won't go wrong, and you won't make a mistake. It's just when people come out telling you what you should do, especially old, hard-bitten sports trainers that have been doing this for 20 years, haven't had real good upgrades, and they think they know everything. They cut every corner going, and they're not going to help you. This is the latest spinal care. This is the latest spinal care. Okay, so you just need to stick to your training.
Sometimes though too, Greg, sometimes you have to argue with the patient as well. Like if they have midline spine pain, but no, I'm good. Sorry.
I know exactly where you're coming from, Yana. We had a young lady up in the territory throwing from a bronc, 2 somersaults in the air, landed flat on her back, had a spinal fracture, told us to F off more than twice and said she was okay. Half an hour later, she collapsed. You know, the adrenaline effect, and this is the problem, the adrenaline effect. She was half charged on rum, okay? She was very petite, very small. The mechanism of injury was horrific. She, you know, it was a collapse situation later on. You know, didn't need to get to that stage. And how much more damage did she do by resisting us and trying to do her own thing for half an hour? This is the problem, and it's quite common. And footballers can be the worst. AFL, NRL, soccer, any of them can be the worst. Yeah, and look, a lot of them will come back to you later and say, "Oh, I'm sorry the way I behaved," you know. But it's just something you're going to have to toughen up for, guys. I'm sorry.
Well, one of the things with concussion is irritability and aggressiveness and argumentativeness, right? So if you have someone who's got a concussion and a spinal injury, they're going to argue with you. That's a sign
fine.
and
symptom. That's exactly
a sign.
Right. And you have the ultimate power. Don't forget, you have the ultimate power of pulling them off the game. If you make the call that they've got a suspected concussion, you level ones will be handing you out some CRT forms at the course, concussion recognition forms. And if they tick one of those boxes, by law, you have to stand them down. It's not as if, you know, you'll think about it. You don't have the authority. You can't do scat tests. You cannot do scat tests. The only person who can do a scat test is a doctor. Okay. What you do use is your concussion recognition tool. They tick a box, they're out, they're gone. And, you know, the coach might say, no, they're not, or yes, they are. And they have to abide by that. I'm telling you now, if AFLQ, well, Sharon's here, she knows what I'm talking about. If AFLQ know that a coach or a club is breaching concussion protocol, they'll take action. So just tell your local AFLQ representative, like you guys up there, I think it's Matty, isn't it? That's your local rep in Rocky that handles that. You know, you let them know, because, and I know that might put some people in the club off with you, okay? Scenario, grand final day, or even worse, you know, preliminary finals.
Greg, can I just interrupt? The AFL's actually got a new app that you can have on your phone as well. It's called Concussion Check. I don't know whether you've heard of it, but yeah.
Good stuff, Sharon. So that's freely available to all AFL people, isn't it?
Yep. It's available to anyone. It's just an app that you get off, your app store. So
all of these apps, the NRLs, the AFLs, all of these apps are based on the concussion recognition tool, guys. There is only one definitive body in the world which it's put through from the Concussion Symposium, and the Concussion Symposium released the rules worldwide. All of your sporting bodies, and AFL has been the strongest supporter of this, may I add. All these sporting bodies sign off on this. It's exactly the same as Queensland schools now. All have signed off on this. And you are required to abide by that concussion recognition tool. Some of them have adapted it, like NRL, and obviously AFL have put it into a form that may be easily, you know, more easily contained by you, but it's still the concussion recognition tool requirements. It's all the same thing, you know, and it tells you when to call an ambulance, and it tells you when not to call an ambulance, and it also tells you when they've got to be stood down, sent off. But what I mean by scene supervising is not only, forget the problems for a minute, it's just having an emergency at your field on the day. Are you prepared for that emergency? Are you prepared to get an ambulance to midfield? Okay, so have you organised that? If you're the sports trainer on duty, or if Paul's going to somewhere and he's working somewhere, Paul knows when he gets there, he's got his game plan out. Where's he going to get an ambulance in? How's it going to get here? He might even have people that'll open the gate for him and everything, okay? You need to know this. First thing, like I'm on a gig this weekend, state titles. You know, first thing when I get there Friday, before the gig starts on the weekend, I'll shoot helicopter coordinates. We'll do the whole lot. We need to know everything. We need to know where can the ambulance come in. We already organise with the officials. They get the ambulance to us. We don't go looking for it. You need to know that at every ground you guys play at, you need to know where's the ambulance access. And I'll give you a factual example how this can go wrong. And this was I won't say what sport, I'll leave this out of it because it's nasty. We were at a state event and it was very, very big. And I got there early and I plotted out how to get an ambulance in. And I went to the roadway to get the ambulance in, and there was a copper's log in a fork across the roadway, padlocked. So you couldn't get in. So I went to them, I said, can't have that, need that moved, need to have free access. And they said, oh, no, that's to stop people driving in there. I said, put up witches' hats. I said, you cannot have a locked copper's log across there. And so they said, why not? I said, if we have an emergency, I said, it can all go pear-shaped. Anyway, it went on and on and on. Eventually the groundsman came, unlocked the copper's log, moved it, okay, and put 3 witches' hats there. Then game started, away it went, everything was happening, very, very busy, lots of work. And we had an arrest on the main field, okay? And it's on. Now, we had 2 things go wrong. First of all, the 000 caller gave the street address, but they didn't say the suburb, okay? And the sister town of this place, it's awkward for me to explain this, the sister town of this place has the same address, run by the same ambulance service, and guess what? They went to the sister town's address. Now, they were taking considerable time, so we called back and they realised their mistake, and then they diverted and sent another crew, or another multiple lot of crews to us. They got on scene. I could hear the sirens coming. We had a result with this patient. We'd had the patient was ROSC, so the patient was awake, but critical. And they have come spinning into the ground, turned in to go straight into where we were. And guess what? The groundsman's put the copper's log back and locked her up. So you know what QAS did? They backed the ambulance up and they just drove at the copper's log, blew it to bits, pulled the Y bars out of the ground and drove straight over the top of it over to us. Absolutely destroyed this structure. And the ground, and here they are on the grounds, and we're all trying to save this patient's life. And this groundsman comes over and he's going off his nut at the QAS paramedics. Some people dragged him away quite sensibly because it was just an amazing situation. So you need to make sure you've got this down pat before the incident happens. If an incident happens and you're now running around to find out what you're going to do, too late, guys. You need to be prepared. You need to be ready for it, please. Please make sure you are. Otherwise, it can be quite embarrassing. Don't be afraid to call for help, okay? If you have an emergency at your field, if you have a cardiac arrest, it's going to take 5 people to handle that cardiac arrest, okay, before the ambulance gets there, okay? So call for help. If I'm on compressions, I will sit up doing compressions and I'll say, any trained people can help me. And I'll do little interviews. So they'll all come in, right? And I'll say, what are you? I'm an EN from accident emergency. Thank you. Can you help us? You know, I'm an off-duty paramedic. Thank you. Come in. I'm a first aider. Yep, see you later. Just sit over there. We'll need you shortly. You know, because he could be really good grunt material for doing compressions, okay? But I'm not going to send away 3 RNs from cardiac care, critical care, for a first aider, okay? So, and this is the thing that's you need to do. There'll be plenty of them there, guys. Don't panic. And of course, scene management, as we were saying before. Please, I hate chaos at a scene. I do not like it. Our clients don't like it. They like calm, okay? They don't care if the patient's leg's cut off and they're pumping blood on the ground. We're not going to yell. We're not going to scream. We're going to do it calm, you know? And so no yelling, no screaming out, no panic. Think before you do it. The millisecond it takes you to think before you act could save a lot of problems later. So just think before you do it. No one's sitting there with a timer saying you've got to act in this time. People can be cruel to you, okay? People can knock what you're doing because they're not on the scene. Don't worry about it. Do your job. Follow your training, and you'll never go wrong with it. And breathe. The big thing is breathe, okay? And communicate to the team. You know, like you need to talk to each other. If there's 2 or 3 of you, all of you talk together, okay? What's happening? There needs to be a senior at the scene. And that's not age. That may be just because you're a bully and you like being the boss, or you're experienced. I don't know. You work it out. Like you asked the scene that Shakala was in the other day. I assumed control of the scene. We had 4 highly trained people on that scene, and they were all doing their job. You know, someone was getting drugs for Shakala. Someone else was cutting pants off. Someone else was, I think we had to do traction on his leg, didn't we? Didn't we think it was female? Didn't we do traction on his leg somewhere or something? I forget now, but you know, like everyone was working as a team. We were all communicating. There was no panic. There was no screaming and yelling. It's just calm, focus. All right. Any questions, anyone? You can all unmute.
Yeah, Greg, just on the getting calls. It's something I've always done. Just my little A4 notebook. I've always written down as soon as I get there my address, the crossroad, the entrance, my telephone number, so I can actually just hand that book to Joe Blow next to me and say, "Can you ring 000? This is what the information you need to do."
Thanks, Paul.
Because we've all run them, so we know what to do. Yeah.
Thanks, Paul. That's a very good point, because some of you will be at an area, and some of you locals will think that it's you know, called something, but it's actually not called that at all. And what Paul's saying is correct. You need to have the address somewhere. Like I don't make a lot of QAS calls these days. I leave it up to the others to make the QAS call for me now in a lot of cases. And we make sure the primary that's making that call, they know the address. They have it written down and they know exactly where to go. Very important. Thanks, Paul. I appreciate that. Okay. Anyone else got any other questions? Come on, guys. Your opportunity to have something to say or to ask a question. No silly questions.